regarding the management of acute kidney injury in children. Mainly, I'm going to highlight the main concepts in acute kidney injury in children. I'm not going into details regarding the particular management of electrolyte imbalances and acid base. It's a huge topic. Therefore, I would like to concentrate mainly on the concepts of acute kidney injury and how to prevent it, and the importance of identifying it early and manage it promptly. To start with, we look into the epidemiology, especially mainly in the critical care setting, because we all know that the AKI risk is very high in critically ill patients. And if you look at this epidemiology study data, in about 1/3 to 2/3 of children with critically ill children or critical illness in a child predisposed to acute kidney injury. But if you look at the percentage of children who need renal replacement therapy, is only about 5 to 6% of intensive care unit patients. Therefore, even though we see acute kidney injury in higher percentage of children who are critically ill, the percentage of children who need renal replacement therapy is far less compared to the the main figures. Then the important aspects when we need to understand acute kidney injury is the staging. Now there are different systems or different classifications when it comes to acute kidney injury staging or definitions. Now if you look at the definition of acute kidney injury based on AKIN network or acute kidney injury network, you can see there are 3 stages: stage 1, stage 2, and stage 3. The most important aspects here is the stage 1. Why I said that? Because that is the area where if you can identify a critically ill child in a stage 1, you can easily manage it without progression into the stage 2. Because we know when come to the critically ill children, one of the main reasons for the acute kidney injury is the pre-renal causes. If we can identify these pre-renal causes, or otherwise, if you can identify it early in the stage 1, we can prevent them by going into stage 2. Therefore, it's very easy for us to then manage in the stage 1, because we can easily stabilize the hemodynamics and get the child out of the acute kidney injury. If you go into another classification of acute kidney injury, this is rifle classification diagnosis of AKI based on the Acute Dialysis Quality Initiative. Now again here, if you look at the risk of renal injury to the kidney and failure of kidney function is much more similar to the AKI in stage 1, 2, and 3. Here again, risk of renal injury is a stage 1 where we need to identify children. That's why it's very important. I think we should understand that every critically ill child should have a baseline serum creatinine. Therefore, please make sure when you are managing, especially children in intensive care unit or any other unit with the critical illness, better or should have a baseline creatinine and baseline urine output. And every child should have a input-output chart, and urine output should be monitored very carefully in all children having a critical illness. Because if you can identify the risk of renal injury by looking at these parameters, if the creatinine is increasing or if the urine output is less than 0.5 ml per kilogram per hour for more than 6 hours, we can identify them early in the stage 1. If you intervene, we can prevent them by going into injury to the kidney or stage 2. There is a concept called golden window. I will come to that. It's where if you can identify this acute kidney injury within first 10 to 12 hours, we can reverse it. If it's gone beyond 12 hours, most of them will go into the injury to the kidney. Mostly what we see in the ATN or acute tubular necrosis, where the management will be difficult, which sometimes we need to initiate renal replacement therapy. Therefore, the main point here that everybody should understand is any child who is having critical illness should have a baseline serum creatinine, and that should be monitored regularly. And every child who is having a critical illness should have a urine output should be monitored very carefully and documented. Okay, now we will look into the causes. As I mentioned, what we mainly see in a critical care setting is, or critical children with critical illness is the AKI or acute kidney injury due to pre-renal causes. The main cause is intravascular volume depletion. It may be due to different reasons like bleeding or renal losses or third-phase losses. What we see in a condition like even dengue hemorrhagic fever, or even we see in sometimes condition like nephrotic syndrome, and decreased cardiac output due to heart tissues or due to the reduced cardiac output. Then renal vasoconstriction we see in hepatorenal disease or even a sepsis. It can cause renal vasoconstriction or hypercalcemia, or sometimes a pharmacological impairment of regulation and GFR in specific settings like when children are on AC inhibitors, especially with bilateral renal artery stenosis. And NSIDs, that's a very important thing that you need to remember, that any child whose kidney is sick, single dose of even NSIDs can cause acute kidney injury when the kidneys are susceptible or they are sick. Therefore, this is an area we need to identify. Thereby, we can prevent them going into acute kidney injury. Now, if you look into renal causes, so intrinsic renal azotemia, these are the main causes. One of the main aspects is renal microvascular and glomerular diseases. We see a lot of glomerulonephritis these days, especially with the post-streptococcal glomerulonephritis, and then hematological condition like HUS, DIC, and can cause renal azotemia or renal failure. And acute tubular necrosis is another important thing. It can be ischemic or toxic, as I mentioned earlier. Now, this is you have to be now pre-renal causes can end up with causing acute tubular necrosis. Now, for example, now stage 1 in kidney disease, as if you look into the staging of AKIN, stage 1 is usually now if you take a hypovolemia, now hypovolemia in a stage 1 can go into stage 2 due to ATN. Now they will get the kidney injury due to hypovolemia. Therefore, ATN is the renal, the intrinsic renal azotemia. But the main reason it could be due to the hypovolemia. If you identify in a stage 1, we can reverse it and then prevent them by going into acute tubular necrosis. That's why I mentioned earlier, identifying in the stage 1 is very, very important when you are managing the children in critical care setting. Tubular interstitial disease is another cause. Some children is having acute interstitial nephritis, and they can have allograft rejection, and viral illnesses like HIV and BK virus also can cause tubular interstitial disease. Other aspect is intratubular obstruction due to myoglobin, myoglobinuria, sometimes use uric acid in hemolysis syndromes, and drugs, especially important like acyclovir. We use not infrequent drug that acyclovir we use in lot of conditions. Therefore, we need to have some idea whenever we start using these drugs. We need to have a baseline serum creatinine, and we need to monitor creatinine and the urine output to identify them early in the disease or early AKI stage. Then post-renal azotemia, what are the causes for post-renal acute kidney injury? Those are very few. They mainly due to the obstruction, due to stones, blood clots, posterior valve, neurogenic bladder. And if you can identify these things, it easily can be corrected or intervened. Now, as I mentioned, I'm mainly today talk is around the concepts of acute kidney injury. Therefore, we look into the pathogenesis of acute kidney injury during an acute illness. What are the predisposing factors, or what are the contributory factors for acute kidney injury? Now, you can see uh, in any child with critical illness can have hemodynamic instability, and their blood pressures can be fluctuate, can be hypertensive, and then sepsis is a part of this acute illness, and sometimes the drugs that we have been used can be nephrotoxic drug, and child can be hypovolemic due to many reasons, and all these reasons together can end up with causing acute kidney injury and aggravate the staging of the kidney injury. Therefore, we need to identify, we need to understand that acute kidney injury in the acutely ill child or critically ill child is a multifactorial. Therefore, all the facts has to be considered and looked into. Otherwise, we may not be able to prevent acute kidney injury. As I mentioned in epidemiological studies, in critically ill child, the risk of acute kidney injury is 1/3 to 2/3, very high. But if you look into these aspects, it can be preventable. But remember that at the same time, even profound hypertension does not always cause AKI. The things that I have mentioned in blue color, you can see not all patients with sepsis develop AKI. I think we all have been seeing these things, and we have all appreciate these findings. Not all patients on nephrotoxic drugs develop AKI. Hypovolemia does not always cause AKI. Therefore, we won't see all the time these uh, factors or risk factors causing acute kidney injury. But remember that when they are together, the risk of AKI is very high, and that's why we need to always monitor these parameters and should keep eye on these aspects. Now, if you look into a little bit in detail pathology, and whatever the reason, especially whatever the etiology, ischemia, toxic injury, or sepsis, there are three main aspects to the pathology of the acute kidney injury. There will be inflammation will be going on, lot of cytokines and chemokine release is there, and it will lead into the inflammation, and there will be vascular injury, and vascular injury will end up with causing vascular leakage and edema, and at the same time there will be a tubular injury starting with tubular obstruction and CAS, and then they will later develop the concentration ability or the concentration ability of the urine. Therefore, whatever the cause, the mainly if it's ischemic, toxic, or sepsis, there are three main aspects to the pathology of the acute kidney injury: the inflammation, vascular injury, and the tubular injury. Now this graph is one of my favorite uh, diagrams I have been using whenever I do lectures, and you can see the volume status of the child and the complications, volume of fluid and the complication. When there is a hypovolemia, the complication is there are more complications. The high rates of complication, there is hypovolemia. And then again, when there is too much of fluid, hypervolemia, there will again more complications. Therefore, there should be a meticulous fluid balance when we are managing a children with acute kidney injury. Hypervolemia should be corrected, and we should not overload the child also. Otherwise, again, the complications will be high. The difficult part of this management of fluid is that there is no such a definite or good technique to determine when fluid are no longer needed. Therefore, it's very difficult to decide on how much of fluid, the adequate fluid amount, but we have to keep in our mind that both hypovolemia and the hypovolemia can cause, or fluid overload can cause complications. We see this in some children with acute kidney injury, or even in sometimes we see even in a dengue fever, dengue hemorrhagic fever. When there is a fluid overload also, there are more complications. And it's same as in acute kidney injury, when child gets fluid overloaded, all the organs can get affected, as you see in this important slides. This slide is all about fluid overload and risk of multi-system dysfunction. That's why we need to find out ways of correcting the fluid deficit but not overloading too much. Because when there is a fluid overload, the edema will affect all organs. There will be a myocardial edema, hepatic congestions, gut edema, cerebral edema, pulmonary edema, renal edema, and the tissue edema. All will contribute to the morbidity and multi-system dysfunction. Therefore, fluid balance should be meticulous, and we need to find out how much the fluid the child needs and try to prevent fluid overload in acute kidney injuries of paramount importance. Right. Now, these are the simple steps in evaluating acute kidney injury in a child. And as I mentioned earlier, obtaining a thorough history and physical examination is always should be a priority. And it's very important to find out what is the underlying cause, what are the physical examination findings related to the fluid status, and review the charts in details regarding the investigation and also input-output charts. And next statement is very important. Do everything you can to do everything you can to accurately assess the volume status. That's very important. That's one of the questions we ask even in whenever we assess children with acute kidney injury. What is the fluid status of the child? Is it hypovolemic or is volume overload is there? Therefore, you need to find out all the ways that you can use to determine or accurately measure the volume status. That is very, very important when you are deciding on your management plan. Always order a renal ultrasound is very important. And acute children with acute kidney injury ultrasound scan is very important. It will give us the details regarding the etiology of the disease, sometimes very helpful. And look at the urine, the color of the urine, whether it is red color, is it very concentrated or dilute urine, you will get a lot of information that just looking at the urine and urine indices and even just the UFR. This is a very, very important aspect. And review urinary indices. What are these indices? Sometimes they are very, very useful. And if you look at the urine analysis, unremarkable in pre and post renal, but it will useful in differentiating acute tubular necrosis versus acute interstitial nephritis versus acute abdominal nephritis. As I mentioned here, this muddy brown cast in ATN is characteristic, and WBC cast is characteristic in AIN or acute interstitial nephritis, and we all know RBC casts are pathognomic in glomerular disease. Therefore, looking at urine, just the UFR or urine analysis is very, very important, and that's why the simple urine investigations will give us very good clues where the pathology is. There is another aspect. When somebody comes with acute kidney injury, sometimes the child may be having an underlying silent chronic kidney disease. That again should be understood. Therefore, that's why I mentioned earlier, looking into the importance of the history and the examination is to identify whether the child is having a long-standing problem and this is an acute chronic kidney disease. Acute kidney injury on CKD can be difficult to distinguish if the patient has not been diagnosed as having CKD, but the proper history, examination, and few basic investigation will tell us whether the child is having a long-standing chronic kidney disease. The information that can help you diagnosis of CKD include past medical history, as I mentioned, is basic history, and the examination is very important. The renal ultrasound scan, we can see small kidneys in chronic kidney disease, and anemia tell us the chronicity, increased parathyroid hormone, hyperphosphatemia. Those are very important features when you look at your investigations, and they will tell you or guide us whether this is a chronic kidney disease and your AKI is on the background of chronic kidney disease. Right. Now, as I mentioned earlier, prevention of AKI in critical care setting is very important, because if we can do that by by looking into the parameters and identify the risk factors early, the big problem or difficult problems will be resolved without much difficulty. Recognition of underlying risk factors is important. You need to look for risk factors like chronic kidney disease, obstruction, or cardiac or liver dysfunction. Those you can intervene there and then can prevent AKI in critical care setting. Maintenance of renal perfusion is one of the key aspects, and avoidance of nephrotoxins. Remember that when you are treating a child with sepsis, it's very important to give a proper antibiotic. At the same time, see whether how you can reduce the nephrotoxicity is again very important. Therefore, we should not give multiple nephrotoxic drugs together, which in a child who is having a perfusion or hemodynamic instability, it can increase the risk of acute kidney injury. Don't miss the golden window. As I mentioned, if you see a child with hypovolemia, and if the child is having oliguria of less than 0.5 ml per kilogram per hour, and if you miss it for more than 12 hours, you end up with child going into acute tubular necrosis. If you identify them before 10 to 12 hours, if you intervene, that is what you call the golden window. If you identify the child within that 10 to 12 hours and intervene, you should be able to prevent the child going into acute tubular necrosis, especially due to hypovolemia in our setting. That is one of the main etiological factors. Now, this is just straight screenshot from the AKS teaching and the risk from the Kidney International on KDIGO guidelines, and it will give us a very good account on how to identify these risk factors and how to manage or prevent acute kidney injury in a critical care setting. You can refer to these KDIGO guidelines. Right, what are we going to do? What are we going to do in a child with acute kidney injury? Remember that, as I mentioned earlier, the treatment is largely supportive in nature. Maintain renal perfusion is very, very important. Therefore, you have to make sure that child is not hypovolemic. You need to resuscitate. After you make sure that the child is filled enough with fluid, still you can't manage, if you can't manage the blood pressures or perfusion, you may need to start inotropes, and therefore try to keep your perfusion, maintain renal perfusion as far as possible. It will prevent, or it will help to manage the renal injury. And correct metabolic arrangement. The correction of metabolic arrangement is itself a different topic. For example, management of acidosis, hyperkalemia, fluid overload, and those are very important aspects. If I can highlight the importance of management of acidosis, the acidosis will affect all organs in the body. It affects the cardiac function also. Therefore, you have to make sure that you promptly look into the metabolic acidosis and correct it as early as possible. Should not leave uncorrected metabolic acidosis for more than 10 to 12 hours. It will affect all organs. Therefore, it's very important whenever you identify a child with acute kidney injury, look at the metabolic acidosis. Severe acidosis can be a factor or can be a risk factor for multi-organ failure. Therefore, never ever forget look into the acidosis, and just don't ignore the acidosis. Just correct it within 10 to 12 hours to make sure that other organs won't be get affected. And at the same time, nutrition is also important. Provide adequate nutrition, and at the same time, make sure that you look after child's nutritional status in acute kidney injury, because it's depend on a lot of factors. Sometimes it can prolong the management of acute kidney injury or the stay in the intensive care unit or critical care settings, and they can get nutritional deprivations, and therefore need to look into nutrition aspects also. Role of diuretics. There are a lot of debates going on regarding diuretic use, but whenever there is a fluid overload and there is oliguria, in our settings, using diuretics is advisable, because if you can get a urine output, even it may be a urine output without any clearance, just like there can be an output but without any effect to the electrolytes, but still it can be important in, because our settings sometimes dialysis facilities are not adequate. Therefore, if you can have a urine output, it will prevent the hypovolemia or fluid overload. Therefore, it may be useful in managing acute kidney injury. Therefore, not all children will respond to diuretics. Therefore, you can use diuretics if there is oliguria and the fluid overload, especially in the form of infusion. And you can just wait for about at least 6 hours and see whether there is response. Don't expect diuretics to work in within a 1 to 2 hour when the GFR is low, when the kidney injury is severe. Therefore, you have to wait for some time and see whether it's going to work. If it works, it will be useful in the management, especially to prevent fluid overload. Remember that even though we think a lot regarding we talk lot regarding renal replacement therapy. Renal replacement therapy remains the cornerstone of management in the minority of patients with the severe AKI. Therefore, not all children with acute kidney injury need renal replacement therapy. They can be managed conservatively and support their vital parameters, and they will recover with time. But some children, they need renal replacement therapy. Now, as I mentioned, one of the key aspects is maintaining renal perfusion. The human kidney has a compromised ability to auto-regulate in AKI. That's why your support is important. Maintain hemodynamic stability and avoiding volume depletion are priority in AKI. Therefore, you need to make sure child is not volumely depleted, and then individual BP targets depend on the age, comorbidities, and the current acute illness. Therefore, you need to look into the blood pressures and keep the blood pressure, especially mean arterial pressure or MAP. You have to look into the MAP and try to keep the MAP. First, you try to try to volumely stabilize the child by giving adequate volume, and after that, without overloading the child, you need to give sometimes inotropic supports and keep your MAP in an acceptable level. It will be very useful to recover the kidney injury. Generally accepted targets remains at least more than 65, but this depend on a lot of other factors too. Now, when do you need renal replacement therapy? That's another thing that the important question that a lot of people ask. And when are we going to start renal replacement therapy? And there are few indications. There are indications to do that. There is some you can say AEI or you. This is for your reference. The acidosis not responding to the medical treatment, electrolyte disturbance like hyperkalemia with ECG changes, with difficulty managed medically, and indications of toxins, and fluid overload not responding to your management, and uremia. Those are very important the indications that we use to decide on whether the patient needs renal replacement therapy. Then right, what are the available renal replacement therapies in our country or in our settings? We have peritoneal dialysis, we have hemodialysis, we have CVHDF or CRRT, continuous renal replacement therapy. And they have their own advantages, they have their own indications, and also we need to find out what is the most suitable way of providing renal replacement therapy to the particular child, depend on the illness, depend on their hemodynamic stability, and depend on the experience on these facilities among the professionals. Therefore, peritoneal dialysis can be used in acute kidney injury, and if it is especially in a child which is also improves efficacy with the improved cardiac output. And then if they can have vascular access, then you have a vascular catheter, and then you can go for the hemodialysis. But you need to make sure that the child should be stable. Having a hemodialysis, if you're going for hemodialysis, his hemodynamics should be stable, because in hemodialysis we take lot of the blood volume will go into the dialysis facility, and therefore they can become hypotensive during the procedure if you want have a hemodynamic stability. Therefore, hemodialysis is mainly can be used in stable children, but peritoneal dialysis can be used in both aspects in the in hemodynamically unstable children also. The problem with the peritoneal dialysis is we don't have a proper control over how much of the ultrafiltrate that we are going to take out. It's depend on the peritoneal dialysis efficacy. And then when we use the continuous renal replacement therapy or CRRT, is mainly for hemodynamically unstable children with sepsis, hemodynamically unstable, fluid overload, or we need to get out some fluid and toxins and cytokines out, and then CVVH or a continuous renal replacement therapy is the mode of action. Therefore, as I mentioned in this very simple table, there are different aspects to the peritoneal dialysis, hemodialysis, and CRRT, and you need to choose the best for the particular children. Therefore, you have to look into a lot of aspects and decide on what is going to be the best for the particular children or particular child. Sorry. Right. Now, because I have been talking about the critical care setting, now whenever we use the critical care setting, sometimes people think that CRRT is always the right choice. Is that so? CRRT is a continuous renal replacement therapy that we have been using in a critical care setting, as I mentioned earlier, especially in the children with hemodynamic instability. Is a powerful life-saving therapy, CRRT. Therefore, we should expand the use of CRRT, especially in the critical care settings, but it has its own risk. But you need to consider the options carefully and individually, whether it's a peritoneal dialysis, intermittent hemodialysis, conservative management, or CRRT, as I mentioned. Take individual child, look into all the aspects, and look how much you are experiencing in particular modality and the facilities, and then decide on what is going to be the best. Do what is best for your patient. Depend on the, as I mentioned, take out all these factors and come to a conclusion. Therefore, my dear friends, now I am coming to the end of my presentation. And finally, these are the points I would like you to remember today. Search for a cause and reversible factors. That's the main aspects or main message that I would like to give when you are managing a children with acute kidney injury. You need to search for the cause and the reversible factors. Correction of fluid depletion is very important, but without causing overload. Because as I mentioned, fluid overload can cause complication by itself. Reversal of hypertension is of paramount importance. Therefore, target MAP at least should be 65, more than 65. Patient with CKD will have more long-term damage from an episode of AKI. Therefore, we need to try to prevent AKI on long-time CKD children. Residual renal function need to be protected. Therefore, you need to make sure that you do or you support every aspect in the body to keep the residual renal function. Finally, when you are managing a child with critical care setting with the acute kidney injury, and you can call your friendly nephrologist early and often, it will be very useful to reduce or to prevent them going into the higher stages of acute kidney injury if you can collaborate with your nephrologist early and often. And thank you very much. This is the end of today's talk.